Hi, everybody. It's Dr. Newman, board-certified plastic surgeon in New York, Westchester, and Long Island. I want to talk a little bit about something that I know is controversial, yet it's something that people talk about and people are asking a lot about. My opinions on this might not be the same as everybody else's opinions, but these are my opinions. People come in asking all the time for fat transfer or using their own fat for breast augmentation. And this is something that personally, I still feel that we need more time to investigate this, to study this, because we live in a world right now, or at least in the United States, where 1 out of 8 women are breast cancer patients. That's a lot of people, and it's so many people that every woman needs to be screened for breast cancer. Fat transfer to the breast is a fat graft. Just like a skin graft where we'll take skin off of the leg and put it on the arm to cover a burn, you're taking fat out of the body and now injecting it into another part of the body. The reason why skin grafts work so well is because what we're placing the skin graft on is an area that has a very rich blood supply. The skin graft is so thin that it may only be 5 to 10 cells thick. So because of that, when we place the skin graft on the arm or wherever this area is, the worst case scenario is that there's a cell that's 8 or 10 cells away from a blood supply. So skin grafts typically heal really well and they heal really reliably. Now, when it comes to us injecting fat for the purpose of a three-dimensional change, well, ideally, if you think about, picking up a ball versus picking up a handful of spaghetti, the handful of spaghetti may feel a lot in size like the ball, but it's really made up of all these little thin strands. Each one of those thin strands is not many cells thick. So because of that, the fat grafts will survive nicely if inserted that way. But the reality of it is that when we do fat transfer and when we're injecting fat into the breast, frequently these kind of tunnels that we're making with our needle to inject the fat into the breast, they kind of keep finding the old path. And although we think we're injecting these little thin strands of spaghetti, we're really injecting more areas and kind of small areas of volumes of fat. And what's in the center of each one of those volumes of fat are cells that are so far away from a blood supply that they don't survive. So we end up with some of the fat not surviving, what we call fat necrosis. And this isn't so much of an issue in the butt or in the face, but in the breast it is, because we need to screen the breast for breast cancer. And one of the ways that we screen the breast is with physical exam. When you speak to patients who've had Brazilian butt lifts or fat transfer to the butt for the purposes of making their buttocks larger, patients will tell you all the time that, yeah, I have these hard lumps there that I feel. And the same thing happens in the breast. I see patients here all the time who have had fat transfer to their breast and have hard lumps in their breast because of areas of fat necrosis. And although it's probably fat necrosis because of their history, how do you know? So what ends up happening is that these patients, even though these lumps that are felt or these areas that are seen on mammograms or on ultrasound are probably fat necrosis, these are patients who frequently undergo multiple biopsies to prove that these areas are not malignant. I think that nowadays mammographers, radiologists who look at breast images on MRIs or on mammograms, they're able to tell the difference between areas of fat necrosis and something in the breast that might not be fat necrosis and might be something that's concerning. But I think it's still an evolving science, and if you speak to radiologists, many radiologists right now will still not use technologies like MRI for the purposes of diagnosing breast cancer. It's something that's still kind of an evolving science, and it's still something that is going to take a while, in my opinion, before we can really feel confident that if there's something seen in the breast, that it's fat necrosis because of fat transfer or something that we should be worried about in biopsying. And as long as I continually see patients who are coming in here upset that they've had these procedures done and are now requiring multiple biopsies, it's very difficult for me to then recommend it for a purely cosmetic reason. Breast implants, as far as my experience and the data that's out there, breast implants are safe. And when breast implants are as safe as they are versus using a technology like fat transfer, which is something that to me has lots of question marks, it's very difficult for me to suggest to a patient that they should do fat transfer and then worry about anything that they may feel in their breasts for the rest of their life. So right now, that's not something that I recommend in my practice. I will not do a fat transfer for purely cosmetic reasons, but I will say that I do use fat transfer sometimes in breast cancer patients who may have had a reconstruction and have a small indentation or a small divot, and something that I think that fat can help fill that void and improve their results significantly if it's on a very visible part of their breast. But these are not patients whose breasts are being screened the same way as the routine patient who's just screening for breast cancer and doesn't have a history of breast cancer. So I think fat transfer has its place right now. I think that in the future it will have more of a place. But in my view and from my perspective, for a purely cosmetic procedure, I think fat transfer to the breast increases the risks and doesn't necessarily give us much benefit. There are patients who are very opposed to having something foreign in their body. So for those patients, if breast implants is really something that's off the table for them, then I probably would push them to do nothing rather than to do fat transfer, at least in today's terms. As time goes on and as mammographers become more adept and as radiologists become more adept at using non-invasive imaging to truly differentiate between results of fat necrosis versus results of other things that need to be pursued, that's a whole different story. And I'm very excited about changing my opinion one day, but I don't think that day is here yet. So as it stands now, this is not something that I suggest in my practice.